All right, what's going on, everyone? Welcome back. We are continuing our lecture series, and now we are in the upper extremity. So we've done our intro stuff, and now we're in the upper extremity sections. Our last lecture was on the shoulder, so make sure you check that one out if you haven't seen it. Today is going to be a shorter one on the elbow, and then we'll finish upper extremity with a hand and wrist lecture, and then we'll go into lower extremity and we'll look at gait, human walking, and some of those topics. So anyway, so today is here is elbow. We'll do like we did with shoulder. We'll look at a bit of structure, biomechanics, different tissues, muscles and ligaments that make up the elbow, and then look at some pathologies at the end and how all this information might be practical to you in a clinical or training type of setting. So all right, with all that being said, let's jump into it. So the human elbow complex is responsible really for shortening and lengthening of the arm so that we can position our hand in space. I've got a cool video here that I took years ago that's a dissection of the elbow. So you can see the rotational ability here, pronation and supination of the forearm, and then the video starts with showing flexion and extension. So you see the bottom of the humerus right here, and then this is, let the video catch up here, the radius and ulna. So there's the shortening and lengthening that goes on with the elbow. When we flex and extend our elbow, we bend and straighten it. And then the rotational ability there of the forearm that allows us pronation and supination. So as I said, it's really, the elbow is important for shortening and lengthening the arm so that we can position our hand in space to be able to feed ourselves and grab important objects. And then it's also, like the knee, the elbow and the knee are very similar. It's a very stable joint, so it gives us some stability. We have a shoulder and a wrist and hand that are fairly mobile, so in between those two we have a more stable joint, which is the elbow. So, and then the forearm, which the forearm really are two joints. There's a proximal radial ulnar joint that we'll talk about in this lecture because it's up inside the elbow joint capsule, but then there's also a distal radial ulnar joint down at the wrist, and those two work together just like the video is showing now to allow us to have pronation and supination. So again, we can rotate our hand and allows us to be able to grab different things in space and manipulate our hand. Okay, so just some basic functional aspects of the elbow. So if we look at the biomechanics of the elbow and sort of the categories, it's considered a uniaxial, one-axis, diarthrodial hinge joint. So remember, a diarthrodial joint, a diarthrosis those are our freely movable joints. There are synovial joints, if you want to just call it synovial joint. That's another way of saying it. And the elbow is a hinge joint. So it just has one axis that runs from medial to lateral. It goes through the elbow, and it allows it to move in the sagittal plane, that forward and backward flexion extension plane. So most textbooks will just list the elbow as a hinge joint. It is a little bit more complicated because we have pronation and supination, but most textbooks will sort of separate the elbow joint and just call it a hinge joint, a one-axis synovial hinge joint. So we'll keep it that way for this lecture. It has 1 degree of freedom. As I just said, it's moving in the sagittal plane. If you remember from the earlier lectures, that's that forward and back plane, the flexion extension plane. It's where we do most of life, right? The forward and backward flexion extension movement. So the elbow really operates in that plane. And then in terms of the joints that make up the elbow, we have the humeral ulnar joint and the humeral radial joint. Basically, if you imagine your humerus is coming down, that's the upper bone of the arm, and then your humerus is articulating with the two bones that make up your forearm. So mainly our elbow is going to be the humeral ulnar joint, where the humerus and the ulna come together. The ulna is the bone you can feel on the back of your elbow, that pointy sort of bone. That one, those two hook together and are connected through all of elbow motion. The humeral radial joint also is an important joint in the elbow, but the bones don't come into contact with each other until the elbow is at 90 degrees or bent more. So when your elbow is straight, the humeral radial joint isn't really touching or being used, so there's not much happening there. It's not until you bend your elbow further that we see the humeral radial joint come into play. And then, there's going to be really 5 muscles and 2 major ligaments that cross the elbow joint that we will talk about. If you imagine, there's a bunch of other muscles and tendons that cross here, but in terms of tissues that really control the elbow joint, the 5 muscles, we've got 3 flexors on the front and 2 extensors on the back. So on the back we have the triceps and anconeus muscle. So we have those 2 extensors. And on the front side we'll have biceps brachii, brachioradialis, and brachialis. And then in terms of ligaments, we've got the medial collateral ligament and the lateral collateral ligament that provide stability on the medial and lateral aspects of the elbow. And those will be ligaments that we'll talk about in terms of overall stability of the elbow and different injuries, valgus and varus injuries, and different sports and activities that can injure those 2 ligaments. So for the humeral ulnar joint, this is just a nice image, I think, that shows how these 2 fit together, just gives us a better image of the structure of the elbow. So again, coming down, we see the humerus here, the upper bone of the arm. Up above here, we would lead to the shoulder. But as the humerus comes down, we have this convex, sort of ball-like structure, and that is the trochlea of the distal humerus. So that's that convex structure, and then that articulates, in this case, with the ulna here on this side. So this is on the inside of the elbow, and that's the trochlear notch of the ulna, and you can see that makes a nice concave structure. So again, like the other synovial joints, we have this convex, sort of concave system where the 2 bones fit together nicely. And you can see here, another reason the elbow is so stable is because of how nicely these fit together. I mean, besides having a strong array of ligaments and muscles, the bones also just fit together really nicely, so they're really congruent, and that means the elbow is really stable. So that's the humeral ulnar joint. And then on the other side, on the lateral side, we have the humeral radial joint. It's a little bit trickier to see here, but I've got 2 x-ray images here. From this posterior view, we can see the radial head, and you can see it has this concavity to it. So a little bit of a concavity, and then there's a bit of a convexity again at the bottom of the humerus. So the bottom of the humerus right here is called the capitulum. So this is the capitulum of the distal humerus, and again is convex. And then the radial head is this proximal portion of the radius, and we'll see this, we'll talk about this again later in some of the pathologies, but that radial head has a little bit of a concavity. And here again, you can see it from this lateral view. There's the concavity of the radial head and the convexity of the bottom of the humerus. Those 2 will fit together, not quite the same as the ulna and the humerus. They do have follow those convex concave mechanics, but as you can see, the joint's not nearly as deep. And as I mentioned before, this joint does not participate with elbow motion until you get to at least 90 degrees of flexion. So when you bend your elbow to 90, anything from there and above, the radial head will start to, this humeral radial joint will start to participate in elbow motion. But when your elbow is straighter than that, it's not touching and participating with the movement. Okay, and then, other joints, again, sometimes these get sort of lumped more into a forearm section, but I want to just mention it here because it's, especially the proximal radial ulnar joint is an important aspect of elbow movement, but we're going to list them as separate joints and not, we're going to think of the elbow as just a hinge joint, and then we're going to think of the radial ulnar joints as sort of a separate area. Our radial ulnar joints would allow us to have pronation and supination. It's that transverse plane movement. So it's again a diarthrodial or synovial joint. It's uniaxial, so it has this longitudinal axis. Remember back when we talked about transverse plane movements, those are movements with a longitudinal axis. So in this case, the axis is going straight through the forearm, which allows for this rotational movement, and it's considered a pivot joint. So again, 1 degree of freedom. This time we're moving in the transverse plane, that rotation plane. And there are 4 muscles involved with these 2 movements. Maybe you can think for a minute about what muscles create pronation and supination. So some of them are really obvious because that is their name. So in terms of supination, we have the supinator muscle up close to the forearm on the posterior side of the forearm, so that helps us with supination. The other really powerful supinator is our biceps brachii. So biceps brachii is an elbow flexor, but it's also a really powerful supinator. So it supinates our forearm and then it flexes our elbow when we're in supination. Okay, and then in terms of pronation, we have pronator teres, which is up here close to the elbow, and then we have another pronator down at the wrist, which is called pronator quadratus. So those two pronators help with pronation, obviously. So those are our four muscles. We've got supinator, biceps brachii, pronator teres, pronator quadratus. Those are the four muscles we're going to think about for movement in these joints. So what's interesting, and the reason I'm mentioning with the elbow, is that if you look at the elbow joint capsule, the proximal radial ulnar joint is inside that joint capsule. So we basically have three joints inside our elbow joint capsule. We have the humeral radial joint, humeral ulnar joint, which we just talked about, and then we also have the proximal radial ulnar joint. So there's really three joints inside your elbow joint. So if that could be, hopefully that makes sense, but you know, we often just talk about the elbow joint and it sounds very simple, but it's really a complex system inside that joint capsule with really three joints where the bones are coming together. So something to think about if you hear about an elbow dislocation or some sort of fracture or elbow fracture, something like that, you have to be more specific and dig a little deeper to find out what exactly happened. Okay, so just a nice image here. I like to show this after because here, this sort of bluish tinted structure is the elbow joint capsule. So the articular capsule, they have it labeled here. So all of the joints are inside here. So here's the ulna, here's the radius. So right here between the humerus and the radius, we'd have our humeral radial joint inside the capsule. And then also inside the capsule here between the humerus and the ulna, we'd have our humeral ulnar joint. And then also that third joint kind of underneath the radiocollateral ligament here, the radius and the ulna, that's our proximal radial ulnar joint. So all three of those are right here inside the joint capsule. This is a nice view of those lateral ligaments. So the radiocollateral ligament, or sometimes it's called the lateral collateral ligament. So you can use both. Sometimes if you use lateral collateral, it's a little confusing because that could also mean the knee. So we tend to stick with radial collateral ligament. And then this is the annular ligament, which is another one that, again, we'll talk about a little later with another pathology, but it basically helps to kind of hold this radial ulnar joint together. It holds the radial head, kind of keeps it right here to create that pivot. So the radial head will spin inside this ligament, and that allows for that pivot joint that sort of helps control the joint and allows for pronation and supination. So kind of just a nice image of the lateral view of the elbow. Okay, a little bit more about the structure. So there's this axis of motion. When we look at the axis of motion of the elbow, there's a slight angulation from medial to lateral, and that creates this thing called a carrying angle, which it's different a little bit from guys to girls, but basically if you were to stand up in anatomical position with your palms forward and standing, you'll notice that your hands, your elbows are closer to your body and your hands are out farther. And that's the carrying angle. So in guys, on average, this is about 5 degrees. The hands will, if you were to take a line and go straight down, there's sort of this 5-degree angle outward. Women tend to have a little bit larger carrying angle. And again, it's a valgus angulation. So the hand is farther lateral than the elbow. That's a valgus angulation. And it only occurs when the elbow is in extension and supination. So your palms have to be facing forward and your elbows straight to see it. As soon as you pronate your forearms or bend your elbows, then your hand is in line with your elbow, so the carrying angle goes away. So you have to be in supination and extension to see this carrying angle. I always used to joke, I don't actually know where the name carrying angle came from, but it definitely makes carrying groceries easier if your arms or elbows are extended and your forearms are supinated. So maybe that's where it comes from. So anyways, that's the carrying angle, and just an image here, you can see it a bit. So we normally have this valgus angle I just mentioned. So right with the carrying angle, there's a normal valgus in the elbow. So if you have greater than that, if you have greater than these average carrying angles, so guys 5 degrees, females 10 to 15 degrees, if you go above that, then we term it cubitus valgus. So you hear about valgus a lot in the knee, right? If people have an increased valgus angulation, we talk about that as increasing injury risk potentially in certain cases. In the elbow, if the angulation is greater than normal, then it's termed cubitus valgus. And again, it tends to disappear when the elbow is pronated and flexed. And this is one of those questions, not so much with the elbow, but people will often ask me about, what kind of exercises can I do to correct these things? And usually, this is something that you develop with. It's the shape of the bones. It's not something that therapeutic rehab exercises are really going to change. So, I think for a lot of people, it's more aesthetic. It kind of bothers them. They don't like how it looks, but it's actually not a huge functional impairment. If it does really functionally bother you, then you'd have to go see orthopedic surgeon. If it's interfering with your function, then you have to go see someone like that. Okay, so joint stability. Let's talk a little bit about stability of the elbow. One, we have the joint capsule. Joint capsule is really important in the elbow. It's different. Remember when we talked about in the shoulder, the joint capsule is really large, so because it's large, we lose some stability, which means with our shoulder we have a lot of mobility. In the elbow, the joint capsule is tighter, and it provides a lot in the way of stability. The elbow is naturally a very stable joint. I mean, if you think about it, it really just has flexion extension. It doesn't have the same degrees of freedom that your shoulder has, so it's just a naturally more stable structure, which means it's also tends to be less mobile. And then in terms of ligaments, we have the radiocollateral and ulnar collateral ligament. I put here in parentheses, sometimes these will also be referred to as the MCL and LCL of the elbow. Again, that can be a little confusing because people tend to think of these names just with the knee. So if you really want to be clear, you could say UCL and RCL. But what's really important here is that the ulnar collateral ligament, which is on the inside of your elbow, helps to resist valgus stresses. So if it stops your hand from being pulled out farther laterally than your elbow. So that's a valgus stress. The radial collateral ligament, which is on the outside of your elbow, that one helps to resist varus stresses. So they really maintain that angulation of the elbow. Obviously, these can be torn. We hear a lot about really ulnar collateral ligament injuries. Maybe a lot of you have heard of this with throwers, like baseball pitchers and things who have to have these Tommy John operations if they tear this. But individuals who are in sports that involve a lot of overhead, high velocity, like a pitcher or somebody who throws javelin, different things like that, they put a lot of stress on this ligament, and it can eventually tear. And in those cases, if it interferes with function, a surgeon can go in and there can be a reconstruction done of that ligament. Okay, so and then the closed packed position, I've mentioned this a little bit before. If you don't quite, closed packed is when we see maximal congruency in a joint. It's when the joint is really most stable. So just breaking it down here, if we look at the humeral ulnar joint, that joint is most stable in full extension. When your elbow's all the way straight, that's when it's most stable. The bones are really matching up the best there, and I think you probably can kind of feel that. The humeral radial joint, on the other hand, is full flexion. So remember, this one doesn't start participating until 90 degrees or more. So that joint is really going to be at maximum sort of contact when your elbow's in full flexion. So opposite ends of the spectrum here for these two joints. Again, the humeral ulnar joint is the one you think about as sort of our main elbow joint, and that is in maximum sort of, the bones are matching up the best in full extension. That's where it'll be most stable. Okay, osteokinematics is where we start looking at movements of the elbow. The humeral ulnar and humeral radial joints, again, are the ones where we see our flexion extension. These are the hinge joints. They would be right up here on the proximal end. These are right our two forearm bones, and the humerus would come down and hook in here, and that's where we'd see our flexion extension. Here again is just a nice way of seeing the proximal radial ulnar joint, that pivot joint that allows for pronation and supination. The distal radial ulnar joint we'll talk about in the wrist, but also contributes to, as part of pronation and supination. So the normal range for elbow flexion extension, if you look at most textbooks, would be from 0 degrees, so when our elbow is straight, that's 0, and we should be able to, if you put a goniometer on here and measure, we should be able to get about 150 degrees, 145 to 150 degrees of elbow flexion. Okay, so that's the normal range there. And then for the radial ulnar joints, it has this longitudinal axis again, because a transverse plane movement, and that's going to run from the center of the radial head right here up by the elbow. It's this oblique axis. See on the diagram here, there's this line for it. So that oblique axis from the center of the radial head down to the center of the ulnar head, and that oblique axis allows our pronation, supination. And what we see there is that we get about pronation, it will be about 80 degrees. So if you measure your pronation, you'll get about 80 degrees. And then with supination, we'll tend to get around 90 degrees. So if you put your elbow at your side, it's probably the easiest way to see it. If you put your elbows at your side with your elbow at 90 degrees, for most people it's easier to get full 90 degrees of supination. So that's with your palm facing up. You can imagine if you had to carry like a bowl of soup, that would be your supination. Your hand can go basically flat. If you turn over the other way, it's hard to get your hand flat when you go into pronation, and that accounts for, on average, about this 10-degree difference. So you should notice that you can get your hand really flat when you go into supination. When you go into pronation, it's a little bit trickier. It kind of stops, and your hand will still be at a little bit of an angle. Okay, so those are osteokinematic or physiological motions. These are the normal. This is the normal range of motion for movements at the elbow. We could put a goniometer on these and measure them. So if you were working in a setting where you don't typically use goniometers, that could be something that you could learn and you could incorporate to objectively capture someone's range of motion. This is something we do a lot in rehab, occupational therapy, and physical therapy to track a patient's progress. Okay, a few pathologies here. Compression injuries are a huge one in the elbow, and this typically happens from a fall on an outstretched hand. Maybe some of you have had this. It's common with skateboarding, snowboarding, skiing. We all have this tendency when we fall down to put our hand out straight, and so it's called a fall on an outstretched hand. So when you land like that, you reach out to put your hand on the ground, your elbow is straight, your wrist is in extension. A bunch of injuries that can happen from that. So really there are better ways to fall, but this is instinctively how we try to fall, and a lot of people get injured from it. In terms of the elbow, we can fracture the radial head, we can fracture the olecranon, we can fracture the coronoid process, all these fractures that can happen within the elbow, inside that joint capsule. So the radius, the ulna, the bottom of the humerus, we can have all these fractures basically because you're landing on this straight arm, your hand hits the ground, all that force goes up through the bones, and there's not a lot of soft tissue to really help absorb that shock. It's just straight into the bones and the joints. As I was mentioning, you can also see above the forearm bones, we can see fractures in the humerus. So it just really depends on how shock is absorbed. This is why I mentioned before, we think of the elbow, we say the elbow joint and think of it as being very simple, but if somebody has a fracture, you want to kind of dig a little deeper and figure out, because there's multiple sites where this could happen. So, this is a nice one for just a nice x-ray here for looking at some of these fractures. We can see evidence here on the radial neck. So, we can see a fracture there. These are there, and then up above on the distal humerus, some evidence of fracturing here. So again, just, we don't have anything here on the ulna, but you want to, when somebody has one of these injuries, just be aware that it can impact any of these three bones, so the ulna, the radius, or the humerus, in terms of fractures with a Fuchs injury. So those are compression injuries. We mainly think about fractures with compression injuries. We'd also think about elbow dislocations, and you can see some kind of gruesome videos out there of people falling, rock climbers, and especially rock climbing videos where people fall from the wall and land like this and dislocate their elbow. I didn't put a video like that in here because it bothers a lot of people, but you can find those on the internet pretty easily. So those are compression injuries. On the flip side, we have distraction injuries where the joint is being pulled apart. In this type of injury, what happens is the radial head, if you remember from the anatomy image earlier, the radial head is held in by the annular ligament. The annular ligament kind of wraps around the radial head. What can happen is that in a distraction injury, the radial head can be sort of popped out of that annular ligament if the arm is sort of pulled out in a longitudinal direction. And this really happens mostly in kids. because the radial head isn't fully developed, so it doesn't fit in there as nicely as an adult does until the radial head finishes growing. So it's commonly seen in kids if they are yanked by the arm unexpectedly. So if they don't have time to sort of activate their neuromuscular system and they're yanked by the hand, it can pull the radial head out of the annular ligament. It's often called nursemaid's elbow, and it kind of looks like this. You can see here the annular ligament isn't present in this image, but the annular ligament would be wrapping around the radial head right here. And again, if the arm is pulled and the child doesn't expect it, the radial head hasn't finished developing, it can kind of pop out of that annular ligament. So that's one, if you work in pediatrics, maybe this is something you see from time to time. I've never had a case like this, but I'm only seeing adults. So just another injury for you to be aware of. Varus and valgus ligament injuries, these are the ones you're really probably going to see mainly, especially the valgus ligament injuries. So this is again when we're thinking about radial and ulnar collateral ligament injuries. And I mentioned javelin before. You can really look at this image and imagine this ulnar collateral ligament. When this individual goes way back here into shoulder external rotation and then goes to accelerate forward to throw this javelin, there's a huge amount of torque put on the inside of the elbow here. And with enough volume and force, that eventually can lead to tears in the ulnar collateral ligament. So, sometimes reconstructive surgeries are done for these athletes because it can really interfere with their performance if that ligament is torn and they lose joint stability. So again, ulnar collateral and radial collateral can be overstretched or torn if the movement continues to occur, and that can lead to pain and instability and laxity in the joint. And as I mentioned before, we really hear about this mostly in baseball pitchers because they are doing such high volume at such a intense force on the inside of the elbow, so much torque there. And so now, right, we have rules, especially in younger throwers, where we limit the volume of throws they can do in an effort to help protect their ulnar collateral ligament and reduce the incidence of these types of injuries to that ligament. Okay, other big ones. So, right, we're going from, we had fractures, and then we're going here into ligaments, and now we'll talk about some other really common ones. These are the ones I probably talk about the most on social media because so many people suffer from them. One is lateral epicondylalgia, or you can tennis elbow, right? Lateral epicondylitis. We don't use the itis name so much anymore because the science on this has changed and it doesn't have really a true, by definition, inflammatory state, so the itis doesn't really make sense. But most of you will think of this as tennis elbow. It affects the extensor, finger and wrist extensors. Their common tendon attaches up here on the lateral epicondyle of the humerus. And so most people will feel pain kind of in this region, up close to the elbow on the sort of top side of the forearm. It is seen in activities where there's high demand on the wrist and finger extensor, so it doesn't have to be, even though it's called tennis elbow, it doesn't have to be racket sports. We see it in tons of people who don't play those kind of sports, so it could be from a lot of typing, writing, gripping type of activities, anything where there's high volume, high load put on the wrist extensors, and the tendon lacks the capacity to handle that. So it most commonly involves the extensor carpi radialis brevis muscle and tendon. So sometimes you hear of surgeons, if somebody's had a chronic case, this going in and kind of debriding and cleaning up that tendon. We tend to not recommend surgery for these conditions because they do pretty well with progressive resistance training that targets those tendons. So we try to stick to the conservative strategies with these types of issues. If the irritation continues and the person maybe doesn't modify their activities appropriately or doesn't incorporate resistance training, this can lead, like other tendons, to tendinosis, where we see this cycle of irritation and then it calms down and irritation calms down. And so sometimes if a person has an MRI and there's tendinosis, the radiologist will talk about the tendon being enlarged and evidence of tendinosis. Again, like other tendons, if it were to continue for a long, long time, you could have tendon failure and tearing of the tendon. Again, not super common. Most people, when it starts hurting, they try to figure it out, and if you can catch them early on, you can use resistance training to build up the strength and capacity of the tendon, and they'll get better. Okay, so that's it involves the wrist extensors on the lateral elbow, tennis elbow, and then the other one we have golfer's elbow. This involves the finger and wrist flexors on the medial epicondyle, so the name changes to medial epicondylalgia. And again, it can happen with some of these sports, tennis and golf, but it can happen with other things too. When the elbow is extended and the pronator teres, remember, which rotates us into pronation, and the flexor carpi radialis and flexor carpi ulnaris. So when those muscles are active over and over and over again in a high volume sense, it can lead to some irritation of that tendon where it attaches on the medial epicondyle. And again, it might seem sort of counterintuitive, but the main treatment strategy is really to improve the capacity and strength of this tendon through heavy, slow resistance training. So basically doing wrist curls, whether you're doing the extensors or the flexors, we're using a dumbbell or bands, and doing heavy, slow curls. That seems to help improve the health of the tendon, reduce pain, and improve function. So on top of that, we've got to have the person modify activities that are triggering the pain. So the rehab exercises don't work very well if you don't also modify the things in life that are irritating it. So there's definitely a balance in those two. But again, two major conditions. You hear about these a lot in the elbow, so lateral and medial epicondylalgia. And then just a few other pathologies to keep in the back of your mind that can happen in the elbow. Dislocations, I mentioned before. There's tons of videos out there of people falling, especially when people fall, they can dislocate the elbow. And because the elbow is so stable, it's a pretty nasty dislocation. Can tear the ligaments, tear the joint capsule. There's a video of an Olympic weightlifter doing this. Usually what happens is the ulna pops off of the humerus and it has this posterior dislocation, and someone has to come in and help reset the joint, reduce the dislocation. Biceps brachii tendon ruptures can happen at the shoulder and at the elbow. If you saw my earlier lecture, there was one of a guy doing a deadlift where the tendon tears off the bone. I think it was in the second or third lecture when we were talking about tension injuries, so you can go back and see that if you haven't seen it. But he's basically doing a deadlift when his forearm is supinated, and bicep, you can see it snap off the bone there. So that can happen in the elbow. And then nerve compression. Nerve compression is one. I get asked about this one actually quite a bit. It's sort of like carpal tunnel syndrome, but this is at the elbow. So the cubital tunnel runs right here on the inside of the elbow. Your ulnar nerve, if you think about, that's where your funny bone is. If you ever bonk your elbow right there, it really hurts, right? And that will cause tingling down into your pinky finger and part of your ring finger and your palm on that side. So the ulnar nerve gives sensation down there. Activities where there's repeated contractions, almost like the golfer's elbow. If you're using flexor carpi ulnaris a lot, it can irritate that nerve. Also, that nerve can get irritated if people are in positions where their elbow's in flexion. Students often get this, where their elbow's bent and they've got their elbow setting on their desk, and they sit like that for long periods, and then they also write and kind of sit on it. Those things can lead to ulnar nerve irritation, and so if that happens here, it's called cubital tunnel syndrome. And we often then incorporate exercises to kind of help loosen up these muscles and then maybe mobilize the ulnar nerve and try to improve the blood flow and health of that nerve. So just a few other pathologies that come up in the elbow from time to time. So that is the end of this lecture. It was a little bit shorter. I hope this is helpful, and next time we will look at the wrist and hand. All right, see you later. Bye.